Hello, this is first laboratory work about anterolateral abdominal wall. Anterolateral abdominal wall is formed by the different layers. The superficial layer is skin, then superficial fascia, then third layer is muscular layer, muscles and aponeurosis, then transversal fascia, and innermost layer is parietal peritoneum. What kind of landmarks we can see on the anterolateral abdominal wall? First, this is linea alba. This is linear depression between the xiphoid process and pubic symphysis. Then costal arch, right and left costal arch. The costal arch corresponds to the lower margins of from 7 to 10 costal cartilages. Right and left costal margin joined in midline and form infrasternal angle. And the most superior is xiphoid process, part of the sternum. Then semilunar line. Semilunar line corresponds to the lateral margin of the rectus abdominis muscle. This is the semilunar line. Then umbilicus. Umbilicus is a skin scar which is situated on the linea alba. Then inguinal ligament and inguinal fold from the superior anterior iliac spine to the pubic symphysis and iliac crest. Next is topographical subdivision of the abdomen and abdominal wall. This division used to describe location of the abdominal organs and the pain associated with the abdominal process. There are two patterns. This is the 4-quadrant patterns. There are two planes, vertical median plane and horizontal transumbilical plane, and these two planes divides anterolateral abdominal wall and abdominal cavity into the 4 quadrants. Left upper quadrant, right lower and left lower quadrant. This is one pattern of the subdivision of the anterolateral abdominal wall. The other pattern is 9-region pattern. There are two horizontal and two vertical plane. Superior horizontal plane is subcostal plane, which passes through the 10 costal cartilages, and inferior horizontal plane is intertubercular plane. Vertical planes are median. The vertical plane passes through the midpoint of the clavicle or midpoint between the superior anterior iliac spine and pubic symphysis. And these 4 planes divide anterior abdominal wall, anterolateral, into the 9 region. Right hypochondriac region and left hypochondriac region, epigastric region, right lateral and left lateral region, and umbilical region. And the most lower are the right inguinal and left inguinal region, and in the middle this is the pubic region. To repeat once again, layers of the anterolateral abdominal wall. First, this is the skin, then superficial fascia, then muscular layer, then transversal fascia, and the innermost is the parietal peritoneum, which cover the internal surface of the anterolateral abdominal wall. Superficial fascia with two layers, Camper's fatty layer and membranous deep layer, Scarf's layer, and in fat people, these two layers are separated in the lower part of the anterolateral abdominal wall. Third layer are the muscle of the anterolateral abdominal wall. There are three lateral muscles and paired muscles, and two also paired muscles which are situated in the anterior part of the abdominal wall. The more superficial is external abdominal oblique muscle. Then second layer is the internal abdominal oblique muscle, and the most deepest is transversus abdominis muscle. All these muscles have the muscular part and aponeurosis, and rectus abdominis muscle is paired muscle. There are two muscles from each side of the linea alba, from the costal cartilages of the 5th to 7th costal cartilage to the pubic symphysis, pubic tubercle. Also in the inferior part is the pyramidalis muscle. These are muscles. About its innervation, attachment, you will learn from the outlines. Posterior abdominal wall. This is the posterior wall of this plastic moulage, and posterior wall of the abdominal cavity is formed by the vertebrae, lumbar vertebrae, and muscles, quadratus lumborum muscle, also paired, and psoas major muscles. This is transversus abdominis muscle, which extend from the iliac crest, lumbodorsal fascia, and inferior internal surface of the lower ribs. We can see also layers of the muscles, anterolateral. This is the skin, fat tissue, this is superficial fascia, external abdominal obliques, internal abdominal oblique, and transversus abdominis muscle. Anterolateral abdominal muscle, paired muscles, form the rectus, its aponeurosis. Their aponeurosis, they form the rectus sheath. This is aponeurotic, this is the rectus sheath. This is aponeurotic envelope, which surround the rectus abdominis muscle. This envelope holds the rectus abdominis in place but doesn't restrict its movement. Its envelope has anterior wall and a posterior wall. This is a cross-section above arcuate line, and this is below the arcuate line. What is the arcuate line? Arcuate line is inferior margin of the posterior wall of the rectus sheath. This is anterior wall, which is cover anterior surface of the rectus abdominis muscle, and this is posterior wall. This left rectus abdominis muscle is removed, and this posterior wall covers only upper 2/3 of the posterior surface of the rectus abdominis muscle. This is cross-section above the arcuate line. Anterior wall is formed from the aponeurosis of the external abdominal oblique muscle, and superficial lamina of the internal abdominal oblique muscle, and posterior wall from the deep lamina of the internal abdominal oblique muscle, and aponeurosis of the transversus abdominis. Below the arcuate line, Anterior wall is formed of the all three aponeurosis of all three lateral muscles, and posterior wall is covered only by the transversal fascia and parietal peritoneum. Inguinal region is inferior lateral part of the anterolateral abdominal wall, and this inguinal region is surgically very important because it is the site of the inguinal hernias in both sexes. What is the hernia? It is abnormal protrusion of any structure beyond its normal place or site. Here, the inguinal hernia, usually parts of the greater omentum and parts of the small intestine can protrude from beyond peritoneal and abdominal cavity, and can be located below the skin. Inguinal region, we can see in that region, first this is the inguinal ligament. It attaches laterally to the superior anterior iliac spine. Medially, its attachment is pubic tubercle, and medial part of the inguinal ligament divides or splits into the two crus, medial crus and lateral crus. Lateral crus attaches to the pubic tubercle, and medial crus medial to pubic tubercle. Here is upper part. This is the thigh. This is the part of the inferior abdominal, inferior part of the abdominal wall. This is the pelvis, and this is the inguinal region, and this is the inguinal ligament. This is the spermatic cord which passes through the inguinal canal. Here also inguinal ligament, superior anterior iliac spine. This is the rectus sheath which cover the rectus abdominis muscle, and this is the spermatic cord. This is internal surface of the anterolateral abdominal wall in the inguinal region. We can see the inferior epigastric blast vessels, artery and vein. Also we can see this is the posterior wall of the rectus sheath. This is the arcuate line, inferior margin of this posterior wall, and this is the rectus abdominis muscle. And this space is Hasselbalch triangle. This is the Hasselbalch triangle. It is very important when we describe the inguinal canal and inguinal hernias. Inguinal canal is situated and is located on the medial half, above the medial half of the inguinal ligament. It has two openings, superficial inguinal ring and deep inguinal ring, which is opening of the transversal fascia. Inguinal canal has two walls, anterior wall, posterior wall. It has a roof and floor. Anterior wall is aponeurosis of the external abdominal oblique muscle. Floor is the inguinal ligament. Roof are the muscles. This is internal and transversus abdominis muscle, and posterior wall is transversal fascia. This is schema of the sagittal section through the inguinal canal. This is through the inguinal canal, and we have to remember once again layers of the anterolateral abdominal wall. First is the skin, then superficial fascia, then external abdominal oblique muscle aponeurosis. This is its anterior wall. Floor is inguinal ligament. Roof are the internal abdominal oblique and transversus abdominis muscle, and posterior wall is transversal fascia. Superficial inguinal ring. Superficial inguinal ring, it is bounded by the medial and lateral crus and intercrural fibers, which are the part of the superficial fascia. Deep inguinal ring is here. That deep inguinal ring is opening into the transversal fascia. This inguinal ring through the inguinal canal passes spermatic cord with in male and round ligament of uterus in female. Internal view, this is posterior wall of the inguinal canal. This posterior wall is transversa fascia, and this here is the opening deep inguinal ring. These are inferior epigastric vessels, and this inferior epigastric vessels crosses the posterior wall of the inguinal canal, and medial to these vessels is Hasselbalch triangle. Its margins of this triangle are lateral margin is epigastric inferior epigastric blood vessels. Medial margin is lateral margin of the rectus abdominis muscle, and inferiorly this is the inguinal hernia, and this is that Hasselbalch triangle. This is internal view, posterior internal view of the abdominal wall at the level of the inguinal region. This is posterior wall, and this is the deep inguinal ring. Posterior wall is reinforced medially by the conjoint tendon, and this is the central part, is the point of the minor resistance of the abdominal wall, and the hernias can pass through this point or through the deep inguinal ring. There are two types of hernia. Direct inguinal hernia protrude directly through the posterior wall of the inguinal hernia and exit through the superficial inguinal ring. It protrude within the Hasselbalch triangle. This is the Hasselbalch triangle, and also that means that is the medial through the inferior epigastric vessels. It is common in older men and rare in women. And indirect inguinal hernia, it passes through the deep inguinal ring, passes through all inguinal canal, and it passes through the deep inguinal ring through all the canal and exits through the superficial inguinal ring. These are protrude lateral through the inferior epigastric blood vessels. They are common in male, in young adults and children, and more common than direct inguinal hernia.